Hello, and welcome to Johns Hopkins Medicine online webinar series. Today, transplant surgeon Benjamin Filosof will be speaking about the benefits of living liver donation. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. To submit a question, please type your question into the Q&A box and click send. Your questions will be seen by others watching this presentation, so please note if you do not want your name attached to your question, please check send anonymously. We will do our best to answer all the questions we've received during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. Please note this program is being recorded. At the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And now I would like to welcome Dr. Filosof to begin our presentation.
Hello, everyone. Welcome to this webinar. And today I'm going to be talking about the benefits of live donor liver transplantation. To start off, I want to talk about how livers are allocated in the United States and how they're prioritized. And the way they're prioritized by what we call the MELD score. So I want to talk a little bit about the MELD score. The MELD score stands for Model for End-Stage Liver Disease, and that's how it came about. It's a score that is an estimate of the patient's risk of mortality while on the transplant list. It uses objective criteria, i.e. labs, to determine how severely ill a patient is, and it significantly reduces or takes away the influence of waiting time. So waiting time really doesn't factor into the MELD score. And it's based on a model that was initially devised to predict the mortality after a certain procedure. And that was published back in 2000. So we've been using MELD for quite a bit of time now. These are the three lab values that we use to calculate MELD, and you can see that the formula is a little complicated, but when you look at these, whatever lab values they are, and you plug them into the formula gives you a score. So if the sicker you are, the higher some of these lab values will be, and the higher the lab values will be when they're plugged into that formula, the score will be higher. When patients are on dialysis, they get a maximum value for creatinine, which looks at your renal function. So the lowest score that you could have, that means if you have no liver disease, your score is 6, and the highest score you could have is 40. So 40 is bad, 6 is normal. And how does the MELD score correlate with mortality? Well, this is actually a nice table and a curve that shows that. So the higher the MELD score you have, the higher the mortality. But you could see that it's not linear, it's more logarithmic. So if you have a MELD score less than 20, your chance of dying from your liver disease within 3 months is still relatively low. But as you get higher, you could see it increase significantly. So somebody who presents with a MELD score of 40, they have a 90% chance of dying from their liver disease unless they're transplanted. So allocation has changed over time. Initially, it went by waiting time and categories of illness, which is just 3 categories. Then it switched to MELD score. And now it's not only switched to MELD score, but it's switched to how the livers are allocated regionally. So now it goes by what we call concentric circles. And the patients are going to have the highest priority are the ones with MELD scores of 37 or higher. And first, it goes within 150 miles from where the donor hospital is. Then it goes from 250 miles and 500 miles. And then it goes to the patients that have MELD scores of 33 to 36, and so on and so on. So you could see if your MELD score is 20, it has to go by many people within a vicinity of 500 before it gets to that particular MELD scored patient. So MELD scores of 37 or higher get transplanted pretty quickly because they draw from a wide area. But if your MELD score is below 37, then that area shrinks. And if your MELD score is 20, for example, it has to be bypassed by all the transplant centers within this area before that liver comes to you. So the MELD score is good because it gets patients who are the sickest transplanted quicker. But on the other hand, if you're sick and your MEL score is not that high, that's going to be a problem. So how's the new allocation changed the way people are getting transplanted? This actually bar graph, which I'll take you through carefully, shows you how over time that new allocation system has impacted how people are getting transplanted. So if you go back in the old allocation system, a lot of the patients were getting transplanted with MEL scores of 24 or less. You can see here over 50% of the patients that were getting transplanted had MEL scores less than 24. Now, if your MEL score is 24 or less, you're about 18% likely to get transplanted. The majority of the patients that are getting transplanted have scores much higher than 24. So you have to be fairly sick to be able to get a liver transplant off the waiting list. And here's another problem that we see. You can see here that the waiting list has continued to increase, actually peaked around 2020 and then has dropped a little bit in 2022. But the number of people getting transplanted has kind of kept up a little bit. There's still a big gap between the number of people that are waitlisted and the number of people that are actually getting a deceased donor transplant. As a result, living donor transplantation has started to increase. You can see it actually has remained relatively flat for a long period of time, and only in the past few years has it started going up. We still having quite a few number of people dying of the liver disease. As a matter of fact, in 2022, 32% of the patients on the wait list died. You can see here, this is the number here, without getting a transplant. So that's a fairly large number of people that are dying waiting for a liver off the wait list. And the other part of it is that when we're transplanting, remember I told you that the males of 37 or 33 or higher are getting the priorities. So we're transplanting people here who are starting to have very high mortality as they wait on the wait list. This graph actually shows you the waitlist mortality, which means if you're on the wait list, what is the chance of you dying with your MEL score? And you can see here, as the MEL score increases, this gets steeper and steeper. So we're transplanting people here. What we really want to do is transplant people here before that curve gets too steep. But if you have, like I said before, if you have a MEL score in the 20s, you're unlikely going to get a liver transplant from the wait list. So this is a big problem. And this is why we do adult to adult living donor transplantations, because we have people who fall into that category where they're sick, they're in the hospital, they have ascites, they're confused, but they're not sick enough by MEL score, and they're not going to have a shot at getting a deceased donor. So we have to do living donor transplantation. So if you look at the first transplant that was performed, we're talking about adult to adult. It was in 1993, so we're really not that far into. We're only about 30 years into doing living donor transplants. And what living donor transplant is all about is using a partial graft instead of the whole liver. And having a partial graft means that your anatomy is more complicated. I'm going to go into that a little bit later. And then as a result, we do have higher complication rates on the recipients getting these grafts. The biliary anatomy could be complicated. The blood vessels are a little complicated. That leads to a higher complication rate. But overall, the survival is actually just as good as a deceased donor transplant. So it's a really good, viable alternative than just waiting until you get much, much sicker and waiting until your MEL score increases. So this is the trend of living donor transplants in the US. We had a peak a little bit in 2001, and we had bad outcomes, and people kind of fell off and lost favor for a while. And it's been relatively flat. So in this country, we don't do that many living donor transplants. And you could see here that the number of transplants that were done in 2019 is only about 445 adult to adult. This is compared to 8,000 are done. So we're doing about 5% of all the liver transplants that are done in the US are from living donors. So it's not a large number. This is not the same in other parts of the world. You can see starting in 2001 that this has been a significant increase in the number of living donor transplants done in Europe. And if you look globally, the US is actually a small number of living donors. This is, I believe in 2015, the number of living donor transplants done is relatively small. Again, 5% of all the transplants done, but you have some other countries where nearly 100% of the transplants are done with living donors. This is the only way they get transplants done because they don't have too many deceased donors. So the number of living donor transplants done is usually inversely related to how good your wait list is and how many people we get off the deceased donor list. So the more deceased donors we do, the less living donors we do. And some of the countries that are very successful with the number of donors they get from people who die and donate their organs have very few living donors, as you can see here. So living donor is an option by default. We don't do it because we think it's a better option. We do it because patients are going to die and they're not going to have a chance to get a liver transplant. So it's life-saving in that respect. So what makes an ideal donor? An ideal donor usually is somebody that has a BMI of less than 30, but I'll show you some data where we're using some patients who have BMIs more than 30 as long as the inside and the liver looks fine. The donors can't have any significant medical problems. I'm not saying any of these will rule you out, but if you have heart disease for sure, you're not going to have a chance. It's not safe enough for you to donate. We don't want to risk injuring the donor in any way possible. So usually we have an age cutoff, although we extended this to 60 years and in some cases we actually go beyond 60 years if that donor is perfectly healthy. And then the anatomy has to be favorable for the recipient. So we prefer a single bile duct, we prefer a single portal vein or a single artery, but it's not always the case. And sometimes we do have to use a little more complicated anatomy. The ideal recipient is somebody with a lower MEL score who's not too sick, because if you're sick, if you're very sick, if you have MEL score 35 to 40, then you really would do better with a whole liver, not just a part of a liver. If there's no underlying kidney disease, so if you need a liver and a kidney, you're better off getting a whole liver and a kidney as opposed to just a partial liver. And then if you have, if you're not that far advanced, what we call portal hypertension, if you're not that far advanced in your liver disease, you're probably going to do better with a living donor transplant. These are rough guidelines, they're not absolute guidelines. So we do actually have to push the envelope a little bit when we're trying to save a life with a living donor. So a lot of our donors come and say, well, what's the chance of me dying? So we look at published data to help answer that question, because it's really hard to know. I could tell you that the death rate is low, but I can't give you an exact number. Well, that paper that was published back in 2012, which is already over 10 years old, gives us that number. So if you look at how many donors died per 1,000 donors, it's 1.7. So your chance of dying from donating is about 0.17%. So you have a 99.83% chance of not dying from donating. So that's high numbers, but we really want this to be zero. That's, we're doing an operation to somebody who doesn't need an operation, who's doing it, who's giving their liver out of the goodness of their heart. So we really want that number to be zero. So even a small percentage is actually too big. And there were some patients that actually needed a liver transplant themselves after donating the liver. That number also is very small, and that number was 0.29%. I'll say that we, like I said, from 1994, this is when we first started doing living donors. And, in the 30 years that we've been doing this, we've actually learned quite a bit and have gotten better at it. So take these numbers with a grain of salt. I think those numbers are much lower now as the country's doing more and people are gaining more experience, they're sharing their experience. And I think the complications and the significant, the bad complications are actually even lower than what you're seeing here. So, but let's talk about other complications. So what are the chances of you having some other complication? Well, there's another publication that came out in 2012, and that that stratified the complications to several different categories, what we call grade 1 to 4. So grade 4 is death, and I showed you that either death or needing a liver transplant yourself. So that's 0.4%. But what are the chances of you having a minor complication? Well, actually, it's pretty high, but not that much different than other operations, but it was 40%. Luckily, most of them were not life-threatening and complications were easily dealt with. A minor complication, for example, is like a wound infection. That could be easily treated, and it doesn't really have an impact on your stay. A potentially life-threatening complication could be, for example, like an abscess. If you develop an abscess in your abdomen from the surgery, if we don't do anything about it, that could be life-threatening, but usually it's easy to deal with and doesn't have any residual lasting disability. So the majority of the complications were mild, grade 1 or 2, easily treatable. There were a few more significant complications, like, for example, if you have a stroke during the surgery, I'm sorry about that. That is also a very low number. So luckily with this operation, the chance of having a significant complication is relatively low. And on the flip end, for the recipient, there are some differences between the deceased donor liver transplants and living donor transplants. So like I said, the anatomy is a little more complicated. So as a result, we do have a few more, for example, bile duct issues that we see with living donors. And this is again across the country. There's not necessarily a single center. This was a cohort of all the transplant centers that were doing living donors. What were the complications? This is what we see. So these are the significant difference between getting a whole liver and getting a living donor liver. You can see the bile leaks and strictures are a little higher. And then there's a slightly higher instance of the artery that feeds the liver going down, because it's a smaller artery than using the main artery, because you're only using the artery that goes to the right side. So we recognize that the complication is a little higher, but given that again, the outcomes with living donor liver transplant is still very good and is still a better alternative than waiting till they get sicker. And actually, I'll show you some data here. So how did these people do long term? Well, this is actually a publication that came out also in 2012 that looked at liver donors, people who donate part of the livers, kidney donors, those are people who donate a kidney for people who need a kidney, and then controls. And you could see they actually all do very well. There's no difference between long-term outcomes with these three. So the good news is, yes, it is risk. There's a small chance that something bad could happen. But if you donate a liver and you do well, 15, 20 years down the road, you're gonna be fine. There's no long-term consequences of donating a part of your liver, which is good to know. And how do the recipients do with a living donor? Like, is it worth putting a person through a living donor operation, or should you just wait on the wait list and get a deceased donor when you get sick enough? Well, so the graph on the left shows you the probability of dying off the wait list. Okay, so if you're on the wait list and you get a living donor transplant, your probability of dying is going to be less over the years that you're waiting on the wait list. So yes, you're better off getting a living donor transplant than just waiting till you get sicker, because some people who get sicker don't get a transplant. They become too sick and die. So the mortality would be higher if you decide to wait for deceased donor transplant from the wait list. So if you're already in a stage where you're already having problems with your liver, you should be looking for a living donor, because that is the best chance that you're going to have. It's going to have the lowest mortality over time. This graph on the right is also looking at probability of death, which it's actually pretty interesting, because it broke it down to getting a deceased donor transplant and getting a living donor transplant. So if you get a deceased donor transplant, if you're lucky enough to get a deceased donor transplant, you're going to live your survival is going to be much better than people who wait a long time on the wait list, as you can see over time. So that's good. If you get a living donor transplant and you're in a center that does a good number of living donor transplants, here the cutoff was 20, and I'm happy to say that we're one of the top 5 centers in the country that does living donor transplants. You could see here that that you do even better. So a living donor transplant has a much better survival than even getting a deceased donor transplant on the list. Certainly much better than waiting on the wait list. So again, this is actually very encouraging. And if you're one of those patients that has a MELD, less than 24, you should be looking for living donors because your survival is going to be the best, especially in a center that is actually pretty, that does quite a few of them, as we do here. So I have a few pictures to show you that when you're dealing with living donor transplants, you're paying attention to a lot of little details in anatomy, because everything is important when you're using half a liver. And we use a 3-dimensional reconstruction of this CAT scan and MRI that a donor gets. And I'm gonna switch and share and show you how we actually do this. This is called NEVIS. So we actually have a company that takes the CT images and the MRI images and puts them together and makes this 3D reconstruction. So let me share. Give me a minute where I could find. Why don't we do this at the end, because I can't, it's not easy for me to find the file right now, but we could actually do that at the end. So let's X out of this. I'll show this to you at the end, how we use this NEVIS reconstruction. But needless to say, it allows us to look at the graft, and we actually tell them, okay, we're going to split the liver about 1 centimeter to the right of this vein here, and we want to know more things. We want to know what the volume is. Okay, so actually we get nice representation of what the volumes of the liver are. So if we're going to take the right lobe, because this is a right lobe, this tells us, okay, that's 63% of the liver that we're taking out. Most of the people have on the average, right lobe to left lobe split is about 65-35. So it's not an even 50-50. Your right lobe tends to be bigger than the left lobe. Sometimes it's 55-45, and sometimes it's 75-25. So we may do an analysis to find out that what we're leaving behind is way too small. And sometimes that's a reason why we turn down donors, is because their anatomy is not favorable. So we have that calculation here. In this case, this person was 63% was the right lobe, 36% was left lobe, 1% was the division line. And then we also have calculations that look at, okay, how safe is this for the recipient, and how much are we leaving behind for the donor? Is it enough for the donor that we're leaving behind? And we have to be very careful with these calculations. I'll show you some of that a little later on. So this 3D imaging really allows us to look at all that very carefully. And this is, for example, another one where we want to give the left lobe, and we have the same thing. What is the graft size? What percent is it? How much are we leaving behind? We're leaving this amount behind. Is it safe? Is this enough for the donor? Is this enough for the recipient? We have all these figured out before we go to the operating. This is a little complicated, this slide, but I want to show you there are some differences between right and left lobe. Most of the transplants in the US are right lobe. Why? Because the right lobe is bigger, as I just said, and because Americans tend to be on the bigger side and require more liver. So people who are on the wait list, really, most of them will need the right lobe because the left lobe will be too small for most of the donors. And there's some differences in anatomy. There's some differences in, you can see here in how much they weigh, but for the most, really what the take home message that I want from the slide rather than reading all this is the fact that right lobes and left lobes are not always the same. Left lobes tend to be a little safer on the donor because we're taking out less. So, but the right lobe is more commonly done because the right lobe is bigger. For the most part, we could take out up to 70% of somebody's liver and they still do well. But if we take out more, that could be an issue for the donor. So we usually have a cutoff about 70%. And there's another calculation that we do as well to make sure that we're leaving enough behind for the donor. So these are the calculations I talked about. How do we calculate whether something's big enough for the recipient? Well, we use what we call graft weight to recipient weight ratio. There's another way to calculate, but this is a standard one that's being done. And we look at the size as showed you with the Nevis imaging. We calculate the volume. We could get a weight based on the volume, and then we take that weight and divide it by the weight of the recipient. So if the recipient's a tiny 50-year-old person, we could probably use the left lobe because we could probably find something that will still be more than 0.8% and be adequate for the recipient. But if the recipient weighs 100 kilos, we're not going to find a left lobe that's that big. So we're going to end up using the right lobe. And even at that, the right lobe has to be big enough because the percentage has to be greater than 0.8% to be okay for the recipient. So this is the main way we look to see if there's enough liver and avoiding this what we call small for size syndrome. And there's a lot of publications that address that, and we feel pretty comfortable with this number, and we do pretty well with these patients. All right, the question then comes up, well, are we too restrictive? Can we, like if we have a 62-year-old donor, is that adequate? Or we have somebody with a BMI that's 33, is that adequate? Well, we do sometimes have to push the envelope. And I could tell you in other parts of the world where there's no alternative, where they have no deceased donors, they do push the envelope quite a bit. And we've learned from how far we could push the envelope. So there's this publication in Canada, for example, that came out of Toronto where they do a lot of living donors. They showed that you can use older grafts. The problem with them is that their older grafts were over the age of 50. We actually routinely used donors in the 50 range and have had good outcomes. For us, older graft means can we use donors over the age of 60? Well, we have a few, we've done quite a few, not quite a few, but we've done a few donors over the age of 60, but they have to be in tip-top shape. They have to have a normal BMI, they have to be physical. The people that we've used, for example, are people who are military people and still very active. So even though their numerical age was over 60, physiologically they're actually they appeared quite young. So the complication rate really is the same. So we actually have pushed the envelope even more than 60 years old. And how about doing sicker melds? Well, if your meld, first of all, if your meld's in the 30s, there's no reason to contemplate getting a living donor because you're probably going to get a deceased donor. Like I said, if you're in the 30s, you're probably going to get a deceased donor off the list. But if you're in the 25 to 30 range, that's kind of no man's land. There are some publications that looked at that, and you could see here, if your meld is greater than 25, if you're doing a living donor, you do take a hit in terms of long-term survival. So there is a difference between getting how long your survival at 5 years. It's 72% compared to 87%. So there is a drop-off in survival when you're sicker and getting a living donor. You could argue that drop-off in survival is also in deceased donor, but since you're likely to get a deceased donor with a MEL score in the 30s, then we usually reserve to 30 or less for living donors. So maybe in some cases we could push the envelope, and between 25 and 30, I think is the gray area. It really depends on the recipient, how sick they are in general, and whether they're going to make it through a living donor transplant with half a liver as opposed to a whole liver. All right, so these are a few pictures of some of the, sorry, I keep on pressing my mouse. Here are a few pictures that show you how a liver split. So this is in the donor, how we split the liver. You can see this is the right lobe cut in half, and the left lobe. Now, we don't cut in half, we preserve the blood vessels and the arteries and the portal vein and the veins that come out here. Everything's preserved. And when we cut everything that's going to the right and leave everything intact on the left side, so we don't have to do any reconstruction on the donor itself. And this is some of the reconstruction we do on the recipients. You know, the veins, we have to use a graft and do separate anastomosis. And so it gets a little complicated, but we do all of this and we are able to push the envelope in this way. But when we push the envelope, we always have to consider and tip the balance towards donor safety. So we can't really go too far and take too many risks. So we will turn down donors because we feel their medical condition is not adequate, or their BMI is way too high, we're worried about complications. So we do think solely on donor safety. That's still a very important aspect of it. We have a team that's dedicated to the donors, where they're not really, they don't really care what's going on with the recipients. Their focus is donor and donor safety, and they're going to look at it as from that standpoint alone. So we do have to separate the people who are working with the recipients and the people who are working with the donors. And we're always tipping the balance towards donor safety. So with that, I'll leave it and take some questions. Okay. So the first question is, what does post-op look like? Well, the liver surgery is not, as you saw from the pictures, it's probably not as straight, it's not a little hernia repair or a little, some minor surgery. It's actually pretty big surgery. So I would say this, that the average hospital stay for donors is probably about 6 to 7 days. And the first few days are rough, but we take actions to try to mitigate the pain and some of the issues that is the toughest part in the recovery phase. For example, we would put an epidural in the donors to make them much more comfortable in the immediate post-operative period. As time goes on, the pain gets better, the patients get better, you ambulate more, and things just get better. So the first day or two can be rough, but we do things that will make it a little easier. And for the most part, people have a pretty good experience, and and don't regret what they do. So, you're saving a life, and I think that in itself is makes people go through some of the discomfort that they have immediately after the surgery. But you could expect to go back home in about 6 to 7 days, and people are usually back to work in about 4 to 6 weeks. So even though you go home, you're not 100%, but you could, when we tell them, when people look at work, when can I go back to work? Usually about 4 to 6 weeks, probably closer to 6 weeks. So, I have to take medication for the rest of my life after I donate. You won't have to take any medication that you weren't taking before donating. So we're not going to, the donor process is not going to add any medication. So if you're already on maybe an antihypertensive, or if you are on some other medication, you'll probably continue taking it, but you're not expected to take more medication after the donation process. And you won't be on bed rest. No, we want people up and about as soon as they can. So post-op day 1, you'll be hopefully walking in your room and then walking the halls. How successful are living donors and PSC patients? I think PSC patients comprise a good portion of the living donor transplants we do. So overall, it's very successful. And the reason why PSC patients it's more important to get PSC patients done. PSC stands for primary sclerosing cholangitis. It's an autoimmune type disease that that attacks the patient's bile ducts. So, people have more issues with drainage of bile and infections related to the bile ducts as opposed to liver failure per se. And PSC is a good example of why we do living donor transplants, because they don't have intrinsic liver disease per se. Their problems are plumbing, so to speak. And their MEL score doesn't always reflect how sick they are. Plus, PSC patients have a cancer risk. The longer they go without a transplant, the more likely they are to develop bile duct cancer. So there's more of an urgency to get patients with PSC transplanted. So they actually comprise a good portion of the living donor transplants that we do, and we have pretty good outcomes. So the next question is, how do you know if the surgery for the donor is open or keyhole surgery? Well, I would say 99% of the donor surgeries are in the US are done open. And that's not necessarily the case in other parts of the world where they do thousands of these a year. And they are pushing the envelope over there and doing what we call minimally invasive surgery on the donors. I do minimally invasive surgery on with liver resections, but the difference in that is that we're not using the liver afterwards. So it's a little easier to do, less risky in that respect. If we're taking out a piece of liver that we want to function 100% immediately on the recipient, we're not going to take any risks. Patients, we're not going to take any added risks to minimize the incision, because the recovery period is still pretty much the same, but the long-term recovery is quicker. So we do want to do keyhole surgery. We want to do it when we feel it's really safe for the recipients, and I think that's probably gonna increase in the future. But right now, I would say 99% of the transplants that are done in the US are with open surgery. What type of complications, side effects are experienced by the donor and recipient? When do you begin the immunosuppressant meds? Okay, so two things. On the donor end, I showed you the data. The complication rate is mostly minor, that we could treat, and doesn't really impact the hospital stay. Occasionally, it may increase the hospital stay if you have an abscess or something that needs to be drained. That is a little rare, but overall, most of the complications luckily are minor. And again, you don't have to take any immunosuppression if you're the donor. If you're the recipient, yes, you will have immunosuppression, just like you would if you had a whole liver. You still have to take immunosuppression because your body will reject what's not you, so you will be on immunosuppression. Another question, I have a blood clot in the portal vein. Will that cause any complications? It does complicate things, but like I said, we push the envelope a little bit. And in a recipient that has a portal vein, if we feel that we could take the clot out during the surgery, then we'll go ahead and consider living donors. If we feel that the portal vein clot is extensive and is going to require some major reconstruction, we probably cannot do that with a living donor. We probably need a whole liver for that. So it depends on the case, and you could address that with your doctors, and we could go over it at that time. Are they taking livers from overdose victims? Are you talking about deceased donor? I hope you're talking about deceased donor and not living donors, but overdose, yes. Unfortunately, there is an epidemic of overdose that we're seeing with some of the drugs that are on the street that are laced with fentanyl. People are buying drugs that are a lot more potent and are dying from overdoses. That's a reality that's out there now. And that's one of the reasons why there was an increase in number of deceased donor transplants in the US. But obviously we're not considering anybody with a narcotic history or a history of drug abuse as a living donor. They have to be, people in good health overall. How long from the time a suitable donor is found to transplant surgery? Well, that process usually takes about 6 weeks. And it's not the fact that it takes us 6 weeks to do things. It's the fact that sometimes scheduling the testing takes a while. So, for example, if we have to get an echocardiogram, we can't get it tomorrow. We usually have to wait about a week or so to get it. So, and then if we find there's some other tests that we need, that's going to take a little bit of time. That'll take another week to get that scheduled. So that adds up. We work as quickly as we can with the donors and with their limits of where they are and how they could get tested. Not all our donors are within arm's reach of Johns Hopkins. We work with donors that are from out of state, and we have to rely on what's available for them in their area for testing. So some of the tests, some of the more complicated tests we get are an echocardiogram to look at the heart. We get a CAT scan and an MRI, and depending on where they are, that could take weeks to schedule. So we try to do the best we can and work as quickly as possible, but sometimes we're bound by when tests can be done. How long until I can return to work after donating? I think I mentioned that. Usually 4 to 6 weeks. It kind of also depends what kind of work you're doing. So we've had donors that have gone back home after, let's say, 5 to 7 days, recovered for another week, and then got on their computer and started working again from home, or even doing half home, half work a couple weeks later. Some are not that motivated. Some are doing, physical labor work, and they're usually, we say, 6 weeks, and that's enough time for them to fully recover. You're still going to be limited in what you could do. We don't want our donors to lift anything heavy for at least 3 months, preferably 6. So if you're, working in a warehouse and the shipping and you're lifting a lot of stuff, that may not be. You have to have accommodation where you won't be able to lift anything for at least 3 to 6 months. But most of the people are feeling pretty good at about 4 weeks and go back to work anywhere between 4 and 6 weeks. Can I donate to someone of my choice, or is it at random? No, of course you could donate to somebody that you want, and that's the idea. Most of the donors that come forward are what we call directed donors. People, for example, if they're sick, they may have a brother that wants to donate. They may have kids that want to donate. So it's usually directed donors. There are people out there who want to donate to save a life and don't have anybody specific in mind, and they find a transplant center through social media or through the web, and they reach us, and we actually have a process that looks at people like that very carefully. But we do rely on what we call altruistic donors to donate. And we've had, I would say, about 10% of our donors are altruistic, and they have saved lives, and they feel very good about doing so. We have people who donated a kidney and have come around and want to donate a liver and have done so. So we have people who donate 2 organs and are still running around and feeling perfectly fine. So altruistic donors, we rely on altruistic donors. In the kidney world, we rely a lot on altruistic donors, and they started chains for paired exchange, very important. So yes, you could do either one, but if you have somebody specific in mind, of course, you could say, I want to donate to that person specifically. What do I need to get on the donation list? Well, I think you have 2 numbers. You have a number on the bottom here that you see on the screen, and you have the website. I would say the easiest thing to do is to go on the website, find the area that says become a living donor. If you click on that, you'll see there's a health questionnaire you could fill. And once you submit that questionnaire, we get it, and then we could start the process and call you as a donor. We cannot, if you're a recipient, you can't call us and say, hey, call my son, he wants to donate. No, they have to initiate the process, and the way to initiate is to make the call either to that number, that 614 number, or I think the easier way to do is to go on the website, find the area where it says living donor transplant, go to the living donation form or the health questionnaire, and fill that out and submit it. And once we get it, we could roll with the process. What does my pre-liver donation evaluation look like? Good question. I showed you some of the requirements, but literally it's basically a lot of blood tests that look at many things. We want to make sure that you are a healthy person for two reasons. One, we want to make sure that you're going to do okay with the surgery, and two, we want to make sure that the liver that we're going to take out is good quality liver. So we look at two things. We want to make sure that, but primarily we're concerned about your health and your well-being. So a lot of the blood tests look at your liver function. We look at things, we do a lot of genetic markers to make sure that you don't have a predisposition to have liver disease 10 to 15 years down the road. We want to make sure you're not one of those people that can form blood clots easily and hence have a pulmonary embolism or have a stroke. So we do all that ahead of time. This is how I think we've gotten better now than we used to 30 years ago, because we didn't have some of these tests 30 years ago. We didn't know who were the people that are likely to develop blood clots. Now we have an idea, so we're gonna, not that we can't use a donor, but now we're gonna take our precautions and give you a little more of a blood thinner so you don't develop blood clots. So we do a lot of tests, a lot of blood tests, but that's to ensure your safety. That's to look at the, how healthy you are, how healthy the liver is. And at the end, we do a CAT scan and an MRI to look at the anatomy with some of the imaging that I showed you. And all right, so that's what, I hope that answered the question, what your evaluation looks like. How common is it to find, by the way, going back to the evaluation, we have, to start the evaluation, we have somebody who's not attached to the transplant program at all. They're gonna call you and they're what we call our independent living donor advocate. Their primary concern is, is it safe for you to proceed, or do you have any issues that will be dangerous to you as a donor? So this is usually a social worker, but it doesn't have to be. And it's somebody that doesn't care about us as a transplant program, that really cares only about you. They'll call you, go through a series of questions, and if they feel it's safe for you to proceed with donation, then you go ahead and we could start the testing. So the first step in the testing process is what we call the ILDA, which is the Independent Living Donor Advocate. You have to, if we can't get through that first process, and if it takes a long time to get through that, then we can't move forward with that. So that's very important. And once the living donor advocate clears you, tells us this person is good to go as a donor, then we contact you and try to get the testing done. And that could take some time. So we encourage you to try to be efficient and try to respond to us as quickly as possible so we get the process going. All right. How common is it to find an altruistic donor? I would say this. I say we get people coming through occasionally. Some of them have requirements. They go, I want to donate to a child. I want to save a child. Some say, so if you're a recipient, I wouldn't rely on an altruistic donor to come forward and give you a piece of their liver. It happens, but it doesn't happen that frequently. I would say 10% of our living donors are altruistic, and even at that, most of them go to children. So I wish we had more altruistic donors, but at that we have to go. I would say you should rely on, if you're a recipient, you should not rely on altruistic donation. I hope that answers the question. What pain level can I expect after surgery? We used to not do any epidurals, and we found that donors tend to have a worse experience than the recipients, because the recipients were chronically ill, they didn't have much muscle, they were wasted away. Donors were healthy, robust, and they actually had more pain. So we have, for many years now, we've been putting epidurals in our donors, which really helps with the pain management. And the epidurals come off about 3 or 4 days after the surgery. And they come off on a time when we could give you pills and manage your pain a lot better. So I think we've gotten really good at managing pain after donation. Good question here. Does the donor's insurance cover their care of the donation surgery, or is that covered by the recipient's insurance? So the recipient insurance covers the donor surgery. So technically, a donor doesn't have to have insurance. We highly recommend that they do have insurance, but it's not their insurance that's going to pay for the donation process. It's the recipient's insurance. All right, I think we have time for a last question. How old do you have to be to donate? I think I gave you the age. I spent a little bit of time talking about older donors. For most programs in the country, and older donors over the age of 50, our cutoff in general is 60 years old as a donor. But in full disclosure, we have used donors over the age of 60 in their early 60s, and but those were very fit people. Those are, marathon runners or people still in the military who are very fit, and we use them knowing that their liver is probably going to be good. So we can go over the age of 60, but that's in a rare cases. Usually, we keep it safe under the age of 60. All right. Well, thank you everyone for joining us. I think we're running out of time, and we'll check out with that.
Thank you so much, Dr. Philosoph, for your presentation, and thank you everyone for attending today's webinar. A copy of recording of the presentation will be emailed out to everyone. Thank you so much.